All dear students, today is the 8th of May 2022. My name is Lexical Kov. I'm professor of the Department of Internal and Occupational Diseases of Kharkiv National Medical University, and I'm going to deliver the lecture in the subject of internal medicine, more specifically in the topic of anemia, and if we get in time, leukemia, for students who are specialized in stomatology or dentistry of fourth year. First of all, anemia. By definition, by anemia, we understand that there is decrease in level of hemoglobin and or red blood cells, while from point of view of clinical approach, we understand that there is a so-called anemic syndrome. By anemic syndrome, we understand all the variety, the sum of all the variety of symptoms from side of clinical science or laboratory ones of background anemia. Triggered and mediated by hypoxia, and further changes in the organism. The complaints, which are typically represented by patients with anemia, include general ones like weakness, fatigue, dizziness, syncopal and orthostatic condition, decrease of memory also. They are non-specific. They are usually present in these patients, but by these symptoms, we cannot differentiate what is the most probable cause or anything. From side of cardiovascular system, we also expect a breathlessness, dyspnea, palpitation. In case of presence of coronary artery disease, there could be worsening of its symptoms. On physical examination, we may detect an external medical examination with pallid discoloration of mucous membranes and skin, and more specifically from side of cardiovascular system, a tachycardia, systolic murmur on the apex. You may see on the slides the typical outlook of such patient. In this case, there is an elder woman, but there could be different ones. Here is the comparison of her hand. She has anemic syndrome, and hand of her husband without anemia. From point of view of the role of dentist in the diagnosis of anemic syndrome and anemia in turn, I must say that it's important to detect the pallid discoloration of mucous membrane of the tongue, of other organs of oral cavity. By this, you may suppose in time the disease, direct the person to proper specialist, and succeed with both treatment of anemia and some specific dental pathology. The laboratory tests help us, or even the only way to specify the exact, for example, for the presence of anemia and its peculiarities. According to the World Health Organization standards for anemia in adults, we stated if the level of hemoglobin is below 12.5 grams per deciliter. Just 2 seconds. I'll change the screen. Okay. Good. In the United States, the values are slightly higher, and anemia is suggested in males with hemoglobin levels below 13.5 grams per deciliter, and in females less than 12.5 grams per deciliter. The pathophysiology of anemia may be described in 3 different aspects. And different types of anemia may be related to different mechanisms of their development. First, a group of anemias caused by the loss of erythrocytes due to bleeding, post-hemorrhagic. It takes place in case of acute and chronic post-hemorrhagic conditions. Second variant is when anemia is a result of increased destruction of circulating erythrocytes. We name this hemolytic anemia. And third type, when there is a problem with hemoglobin, of production of hemoglobin or with circulating hemoglobin in the blood. The typical case of this kind of anemia is iron deficient anemia, when there is a problem with hemoglobin synthesis due to lack of iron, either in the meal or absorbed into the organism, or metabolization of it in the organism. The other example is vitamin B12 and folic deficiency, which may also result in so-called megaloblastic anemia and even aplastic conditions of blood system with anemia as a variant. The classification of anemias is variable, and there are different approaches to it. The first one we have already mentioned is pathogenetic. Other one is by a degree of severity. We distinguish 3 stages or degrees. Mild, when the decrease of hemoglobin is up to 20%, less than 20% from initial. Moderate is if this decreases within 20 to 40, formally 39.9%. And severe if decreases more than 40% from norm. And the change of hemoglobin concentration within 5% is considered as average norm, so we do not take it as a problem. The third approach to classification is classification of anemia is based on ability to regenerate. By this approach, we distinguish also 3 types of anemia. Normal regenerative, when reticulocytosis count is between 0.2 to 1.2%, or hyporegenerative, when reticulocytosis is less than 0.2%, or hyperregenerative, when the reticulocyte count is exceeding 1.2%. The fourth type of anemia is when we distinguish them by the contents of hemoglobin in erythrocytes. We distinguish hypochromic, when mean corpuscular hemoglobin concentration is less than 32 grams per deciliter. It's typical for iron deficient type of anemia. Hyperchromic, when mean corpuscular hemoglobin concentration is exceeding 36 grams per deciliter. It's typical for vitamin B12 and folic deficient anemia, or it's also named megaloblastic. And finally, we have normochromic, when mean corpuscular hemoglobin concentration is within 32 to 36 grams per deciliter. In the majority of other kinds of anemia, it's normochromic. The fifth approach to classification is basing on the diameter of red blood cells. We distinguish normocytic. The mean corpuscular volume is about 84 to 96 fetal-liter. Then microcytic, when this parameter is below 84, and it's typical for iron deficiency, for hemolytic anemia, and so on, especially chronic hemolytic. And we have microcytic, when this parameter is exceeding 96. It's typical for vitamin B12 folic deficiency. The sideropenic syndrome, let's start from iron deficiency. From side of skin, there are mostly changes of the skin itself and its derivatives, and mucous membranes even, such as dryness of skin, fragility of hair, and bending of nails. The nails become flattened. Sometimes they may have a concaved form, so-called coilonechiasis develops. On this slide, I try to represent the typical changes on the lips as well. There could be some dystrophic changes like this, and more examples. And you as dentist might detect this and suppose the proper diagnosis and either administer the simple complete blood count or direct the person to physical to generalist, to general practitioner. Here are some changes of the nails and skin. Other aspects of sideropenic syndrome includes from side of gastrointestinal tract, for example, there is decrease and distortion of appetite, dysphagy, constipation, so diarrhea, glossitis, esophagitis, and so on. Here are some typical changes on the tongue, which again, you as dentist might detect and support the disease in time and conduct the proper treatment. There are also sometimes unusual predilections for some smells, acetone or petrol, the symptom of angular stomatitis or gingivitis, or labiitis, as well. The distortion of taste, desire of chalk, toothpaste, ashes, paint, the swallowing of abnormality with sensation of foreign body in the throat, and so on. The causes of development of iron deficiency conditions relate to blood loss. Vegetarians may also experience these problems because of lack of absorption of iron from the food. The prolonged achlorhydria may also be a cause of this condition. Extensive surgical removal of proximal small bowel or chronic diseases such as pancreatitis, enteritis, etc. The increased iron requirements as well, from birth to age 2 and during adolescence. During pregnancy and lactation may be also present. The laboratory studies help to detect that, for example, in chronic iron deficiency anemia, the cellular indices show a microcytic and hypochromic erythropoiesis. There is a decrease of iron concentration as well. The normal serum iron is between 13 and to 27 micromole per liter for men and 11 to 25 micromole per liter for women. The increase of iron binding capacity takes place in these conditions. The total iron binding capacity is normally from 45 to 81 micromole per liter. The decrease of serum ferritin is one of also parameters we detect, and the range of normal value in most laboratories is between 30 to 300 nanograms per cubic meter. Microliter, pardon. The decrease of sideroblasts in the bone marrow aspirate takes place as well. Normally, they are 20 to 40% of sideroblasts. The medical care in case of sideropenic syndrome in general and iron deficient anemia as well is first diet correction. The iron uptake takes place in the proximal small bowel. So the dietary iron contains both ham and non-ham iron, and meat, animal products provide a source of so-called ham iron, second valence. The purified ham is absorbed poorly. Second approach, if we do not succeed with diet, is use of medications. The ferrous sulfate from 100 to 300 milligrams daily is indicated. If this doesn't help, perorally, we use it in parenteral form by injections or infusions. And we use parenteral way if there are some problems with absorption of oral iron, or we detect the increase in anemia despite the adequate doses of oral iron. The second variant of anemia is megaloblastic one. The molecular basis for megaloblastosis is really in the synthesis and the assembly of desoxyribonucleic acid. The most common causes of megaloblastosis are cobalamin and folate deficiencies. The prevalence of megaloblastosis is enlarged with the years and makes up young persons about 0.1%, at elderly up to 1%. Women are sick more often. Pathophysiologically, the dietary intake, meat, liver, kidneys, eggs, milk, cheese, beans, is the source of cobalamin and folate, because humans cannot synthesize these substances by themselves. And cobalamin must be bound to intrinsic factor secreted in the stomach, and this complex is taken up in the terminal ileum. The cobalamin enzymes, the metabolism of nucleic acid and its deficiency, mitotic processes in fast-growing tissues, a bone marrow, an epithelium, gastrointestinal tract are broken. The exchange of fat acids, synthesis, and neogenesis of myelin, and at its disadvantage, these processes are broken. Also, defect in adenosylcarbonyl-dependent conversion of methylamonyl coenzyme A to succinyl coenzyme A also exists. The causes of cobalamin deficiency include nutritional deficiency, food cobalamin malabsorption due to, for example, gastric acidity, absence of functional intrinsic factor, severe abnormalities in the terminal ileum due to ileal resection, regional ileitis, or lymphoma, helminthic invasion, blind loop syndrome, use of drugs such as cytostatics, anticonvulsants, oral contraceptives, non-steroid anti-inflammatory drugs, some anti-diabetic drugs, colchicine, and others. The clinical features of vitamin B12 and folic deficiency are anemic syndrome, jaundice, gastrointestinal manifestations, including anorexia and diarrhea. From side of oral cavity, there could be sore tongue with which on inspection will be smooth and beefly red. Neurologic manifestations include numbness and paresthesia in the extremities, weakness, ataxia, sphincter disturbances, diminished or increased of reflexes, positive Romberg and Babinski's signs, diminished position and vibration senses, disturbances of mentation, etc. On laboratory investigations, we may detect macrocytosis, fully hemoglobinized erythrocytes. Neutrophils show hypersegmentation of the nucleus. Leukocyte and platelet counts may be decreased. Here is the outlook of nucleated red blood cells. The decrease of serum cobalamin level is the specific laboratory sign of this condition. The normal range is 3 to 900 picograms per milliliter. Bone marrow aspirate is hypercellular with a decreased myeloid to erythroid ratio. Megaloblastic red blood cells precursors are abnormally large and have nuclei that appear much less mature than would be expected from the development of the cytoplasm. Nuclear cytoplasmic asynchrony. The nuclear chromatin is more dispersed than expected, and it condenses in a peculiar fenestrated pattern. Abnormal mitosis may be also seen. Here are the slides of this condition. Then, in laboratory studies, we may detect the increase in unconjugated bilirubin and lactic acid dehydrogenase in plasma, and abnormal X-ray films, upper and lower GI gastrointestinal series, and computer tomography scans. The medical care in this case is supply of cobalamin, about 1,000 micrograms parenterally daily for 2 weeks, then weekly until the hematocrit value becomes normal, and then monthly for the life. Next type of anemias includes hemolytic version. The hemolytic anemias is a group of the diseases which are characterized by the raised intracorpuscular inside the cells or cytophagus system, or extracorpuscular in a vascular channel, destruction, hemolysis of erythrocytes, and decrease of duration of their life, less than 120 days. There is a variety of approaches to classification of hemolytic anemias. For you as dentists, non-specialized in therapy or hematology, we do not study it too deeply. The clinical and laboratory signs of hemolysis include the following ones: the anemic syndrome with a normochromal anemia, reticulocytosis, jaundice of skin and mucous membranes, hepato and splenomegaly, augmentation of the urobilinogen content in urine, augmentation of the stercobilinogen content in feces, level of unconjugated bilirubin elevation, low or absent levels of serum haptoglobin, rising of a level serum iron. The lifespan of red blood cells may be shortened, erythroid hyperplasia of the bone marrow. The acquired hemolytic anemia are also heterogenic. There could be different reasons of this. And part treatments, the immune, traumatic hemolytic anemia due to toxic effect on membrane, paroxysmal nocturnal hemoglobin, urea. So there could be different versions. We will not discuss all of them, but you may do this at your practical classes. The clinical manifestations in this case are aiming on, or they are most expressed in form of anemia, in laboratory, of course, studies, spherocytosis, splenomegaly, venous thrombosis, positive direct Coombs test. The treatment is complicated, so we probably will not focus on them, but I think it depends, of course, on the cause, mechanism of the anemia. Let's continue with the next type of anemia and probably finish for today. The aplastic anemia is when a bone marrow failure develops, and it is characterized by peripheral pancytopenia and marrow hypoplasia. The epidemiology of hypo and aplastic anemia depends on different reasons. You will study at your practical classes. The classification also probably you'll discuss it later. Clinical manifestation: anemic syndrome, hemorrhagic syndrome with bleedings, nasal, uterine, gastrointestinal, from oral cavity as well, and so on. Ecchymosis and petechias all over the body, and syndrome of infections, infectious complications. On laboratory studies, paucity of platelets, red blood cells, granulocytes, monocytes, and reticulocytes we detect. Bone marrow aspirate from iliac crest shows mostly fat under the microscope, with hematopoietic cells occupying less than 25% of the marrow space. Here is the outlook of this condition: normal and aplastic anemia. You may see how different they are. The treatment, of course, in this case, we may use bone marrow transplantation, anti-lymphocyte globulin, infusion, anti-thymocyte globulin if there are autoimmune causes, cyclosporin A in appropriate cases, and supportive care like antibiotics against bacterial infection, antifungal drugs against mycosis, erythrocytes, and platelet transfusion to supply the person. Pardon. Okay, so in brief, we have discussed the anemia. The rest of topics are placed in other recording. So I stop the recording and upload it for you